we will do a little Q&A. I'm going to grab a handheld microphone so I can walk it around the room. If you have a question, just throw your hand up. Be happy to bring it to you. Also, if you're on the chat and you're watching from home, feel free to put a question in the chat and we can ask it to the panel here as well. Here, Barb, I can put your potatoes here. Okay, we got a question in the back.
Good morning. Dr. Patel, can you explain the difference between the insulin pen that you described today, and I'm currently using the other, I guess, the regular type of insulin pen.
Sure.
It looks the same. I just don't know if there's any major difference. And would it work, does it only work with a certain app or, like Dexcom or Libre Link? Because I have the Libre, the sensor too.
You have the Libre? Yes. Okay. So the InPen, the way that it will work is if you are prescribed Humalog or Novolog, then that pen is you just administer, you turn the knob and so forth. With the InPen, you could be prescribed a cartridge of Humalog or Novolog, the same cartridge that would be in the other traditional insulin pen. That cartridge then would be placed into what I spoke of today, the InPen, and that linked to a software app, meaning on your phone, provided by InPen. So it's InPen's pen and it's InPen's app. And when you use the insulin that's within the InPen now, all of that data, meaning I'm prescribing or administering 5 units of insulin, will be logged into that InPen app. And then you have all the benefits of what the app has to offer. So for example, a logbook, the recording, the calculation, if your provider has set it up in such a way. I will say it's a niche product, meaning most likely an endocrinologist will be aware or knowledgeable how to operate that app for the setting calculator part. So how to calculate your insulin. It can do calculations on its own, but it's not where a doctor is making another change. Oh, you're taking more insulin, or you need more insulin, so I will change the settings for it to give you a different kind of advice. So with the help of an endocrinologist, so it's almost like here's your pen that you're currently using. Here's an InPen with the new cartridge of insulin in the InPen. It pairs with an app to keep everything on record. Then a provider then looks at all of that record and says, you need to do this now. Hopefully that answers the question, but it is a proprietary app.
Will my doctor, my doctor has access to the app and, downloads the app. Will my doctor have access to that InPen app?
So in my office, yes, I have access to that. And there is a computer software on our end that incorporates it all and gives me a robust amount of information that's like as long as I want. So the entire last 3 months that you've been living life. So yes, the answer is yes, in the right hands.
Thank you.
Mm-hmm.
Good morning. Okay, my question, I would imagine, is to this doctor or maybe anyone up there. You mentioned seven, it was your glucose level, and you said you're pre-diabetic, which to my understanding, I was taught, they say there is no pre, you either are or you're not. But my question is based on when I first was diagnosed, I was 7.1 or 2, and they put me on a bunch of pills. I'm not on insulin. They put me on pills on exercise and diet. I managed to bring it down to like around 6. She said she wanted me at 6.5. I got to 6.5, and then on the next within a year or two, they said that the number had dropped and now it's 6 point. And so then I got it to 5.9, and she said the number has dropped. It's 5.7. So I want to know, why are they doing that to keep us on drugs? To benefit the pharmacist, or why every time you get to a level it changes?
So first, the example of the 7.0 on that document in the presentation was not mine. So I don't have a 7.0. I have a 5.9 as far as I know, which is similar to your 5.7. And that is in the pre-diabetes range.
But what is pre-diabetes?
Yes, 5.7 to 6.4. So that original 7.0 that you had, along with one other time point, would be diagnostic criteria for diabetes. Yes. Then, according to which guideline you choose to follow, someone's HbA1c goal would be 7.0, someone's would be 6.5. Arguably, some people could even be a 6.0 with or without medication. So in my case, in my office, with the cooperation of the patient, we have a discussion to say, okay, you are now at 7.0, let's continue your metformin, for example. Oh, great job, congratulations, you're at 6.5. That meets criteria for the American Association of Clinical Endocrinologists goal of diabetes control. So you're at 6.5. Keep your metformin going. Unless you prefer to follow the American Diabetes Association's HbA1c goal of 7.0, in that case, do you want to reduce your metformin ever so slightly and let your sugars go up to 7.0 because you're on less medications? I don't know that I would necessarily advise that, but I could advise that. Now, let's go down to 5.7 where you are now. That's better than mine. So I don't take medications, and I would want that for you as well. So with that understanding, absolutely, I would want to titrate you off of medications as much as possible through your due diligence of exercise and diet. Those are your rewards. Your rewards are to take away medications, and that includes for blood pressure and cholesterol too, but like when you have a diagnosis of diabetes, there are things like remission of diabetes, there are controlled diabetes, and there's uncontrolled diabetes. I would consider them 3 different levels. So if you are in remission, that means you've achieved diabetes diagnosis, but you've achieved it without medications. Goal. So that's what I consider.
They reduced the metformin from 4 to 2 to 1.
Yeah, exactly. Great, yeah. So yeah, we're not all drug pushers, right? We're just trying to get you off.
Yeah,
All right.
great question and great answer.
I'm enjoying the presentations, everyone, and thank you. My question is, normally when I go to diabetes forums and whatever, they at some point mention diabetes 1 or 2, but I've not heard one of you at all mention that. So is it for what you had to offer, the pens and everything, it doesn't matter if you're 1 or 2, or this is not for one group, or how does that work?
I'm assuming that's to me.
Yeah.
Yeah, no, I think everyone can have an opinion on this. So the lines are becoming more and more blurrier or together as time goes on. So what was originally considered for type 1 only sensors and pumps are now more so,
Yeah.
they are becoming more and more prevalent in the type 2 diabetes community as well, particularly the sensors. And that's why I wanted to focus on that portion of the presentation, because it is becoming more accessible, is becoming more affordable, and is becoming more valuable for that group of people, the sensors specifically. The InPens, now that I've had a chance to operate them, they can definitely you can definitely benefit from them in either world. Typically, type 1s benefit from it a little bit more, I would say. For example, that half unit increment. Type 2s won't necessarily see a difference in a half increment insulin, but type 1s that require only 5 units of insulin to stay alive, 0.5 could mean life or death. So I think there's more benefit there in that world for them. But with that being said, I've seen it used for type 1s and type 2s, and I think one cool thing that I did not mention, I was meaning to mention during the presentation, is it has notifications. I've been getting notifications all throughout this last week saying, hey, you forgot to take your insulin. And And a lot of my patients will miss the mealtime insulin. So if you are taking 4 shots of insulin per day, it is easy to forget. And if an app is there to support you to say, hey, I know when you take your insulin and I know when you don't, and you missed lunch. And did you miss lunch? And if you didn't, fine. If you did, this is your reminder. There's research that shows improved adherence, meaning I'm taking the medication when I'm supposed to based on that usage for type 1s and type 2s. And the outcome ultimately leads to greater time in range. So it's for both. Pumps, third part of my presentation. Also, as time goes on, you're seeing benefits there. But I did mention that there's a complex initial learning curve. The application, fine, but the usage of the software is very, very important to know how to operate that insulin pump, which is administering insulin at all times. You want to make sure that you understand that pump and how it's operating. And I feel like it can benefit type 2s as well, but typically it's been in the type world. But the sensor, without question, I think, in fact, the American Association of Clinical Endocrinologists recommend, and I think the ADA may have already started this concept too, that they recommend it for anyone that's taking insulin, standard of care is sensors. So going forward, it's very prevalent in type 2 community.
I want to add one more thing about the sensors related to use it for type 2 or type 1, because we've really seen that progress. It used to be really focused on people with type 1, and now we said, okay, also people with type 2 on insulin, especially if you are prone to low blood sugars. Well, just recently, Medicaid of Ohio now covers all people with diabetes, type 1, type 2, whether or not you're on insulin, for a sensor. So just to show you the progression, and just that's part of the reason we're talking about technology today, is it's changing and it's exciting. Not Medicare.
It's coming though. It's
Yeah.
Medicaid and Medicare are just right in line.
Yeah.
When I was first diagnosed with diabetes, the goal was to be at 6 or below. And now when I went in and my guy said, he says, oh, you're 7.2, you're doing so good. So are the standards changing? I mean, with all of the research and stuff? Or I guess I don't understand why all of a sudden 7 is good when the whole goal was for me to be lower.
I can go on and on and on about this. So I'd love to have a conversation with you on the side, but it's to summarize the answer so that we all understand why. Yes, we are accomplishing more and more research. We are finding out that a 7.0 is not the 7.0 for you versus a 7.0 for a 13-year-old. We have different goals for different age ranges predominantly, and then also duration and length of diagnosis. So when you were first diagnosed, and perhaps when you're on metformin, we want you to be below 6.5. My goodness, if we could do that with a low blood sugar, that's outstanding. The lower, the better. But when you have cardiovascular disease, when you have 25 years of history of diabetes, when you have some amount of renal impairment, we have evidence to suggest that it's not so beneficial to your heart to drop your sugars very, very low. If we can accomplish it with metformin, just as well, fine. But typically we have this more lenient aspect. One last part about that, because I want everyone to be engaged with this. I had my grandmother. She was about 89. When in the last 2 or 3 years, her quality of life was back and forth bedroom, and she spent time with her family and all. But I was perfectly happy and content with her A1C being 9.0. The issue here is how long are we trying to live? And so if you're 35 and diagnosed with diabetes, well, sure, 7.0 matters, a lot in the long range of things. But for a new diagnosis at age 85, and you're really only going to live to 100, let's pretend, and we're not going to lengthen that life or shorten that life by a tenfold factor or 10 years. We're just not going to. So why are we causing a low blood sugar that's sending you to the hospital or something more harmful in that? So we're a little bit more lenient as time goes on.
My question probably doesn't apply to a lot.
Okay, I don't take any medicine. I don't take any insulin anymore. My question is, how do you lower your sugar when you've eaten something. Like you said, okay, I ate some eggs to get it down. How do I do that?
Water. Water or burning calories, yeah.
You know,
walk and burn,
basically,
yeah.
exercise and medication lower your blood sugar, and eating and stress raise it. So, sometimes, I mean, there's only so much low carbohydrate meals you can do to get by. So if if you don't want to do a keto diet and you want to have moderate carbohydrate, there are times when, and you've maxed out your exercise, there might be a time where you need medication. There's only so low of carbs you can eat for long term, and feel good and enjoy life. And so we do a balance between exercise and what we eat. And
You've eaten something and you know it's going to make it go up.
there's really nothing besides exercise and drinking a little extra water that's going to bring it down without medication.
I think I heard Dr. Patel at one point saying some of the protein might help drag that sugar out. Can you guys maybe explain what combining a protein with a carb might have an effect on that?
Go ahead.
So if you have maybe more of a balanced intake, so you're using some protein and some fats, ideally plant fats, with your carbohydrate, doesn't cancel the carbs, but it lowers how fast they're digested. The whole meal is digested, so it's not getting into your blood as quickly. So we call it lowering the glycemic effect of the meal or the eating episode. So that's something you can take advantage of with meal times or snack times, that you're having a balanced intake. So if you're eating an apple, let's put a string cheese with it, for example. A typical lunch dinner often is like a protein source, a vegetable. Those are both low carb items that kind of balance out then if you add some grains with it or some starch or carbohydrate. Breakfast is a tricky one. I would look at your breakfast. A lot of times we don't balance that very well. So think about, by having a good protein source, healthy fat, like avocado toast, or we like eggs at breakfast, or Greek yogurt. What's my protein at my breakfast is something to think about.
I'd like to also add, when you, for example, I have a fairly good habit of eating my dinner earlier because I can then go for a walk after. And so walking and movement and burning calories, or even going for a workout, will lower that blood sugar. So if that's what you're attempting to do, that it's way better to do that than, not way better, but versus going for a walk and then eating and then going to bed on that. So if you have a late night dinner and no physical activity after, that sugar will remain higher for longer. So that physical activity, even just daytime random activity, is good, but walking after eating something heavy is something actually I think that we used to do, in our culture, and I think we can, if we're not already doing that, we can go back to those roots.
That's a great tip, because I like to go home and go for a walk and then eat, but that's easy to switch that routine,
Right,
and
yeah.
it'll make
Yeah,
a positive
you're doing the same
impact.
stuff. This might be better.
Great, thank you.
I wish we could get a little bit more clear on the type 2 qualifying for the sensor or not. I've been trying to figure that out. I was surprised. I have type 2, and my doctor ordered a sensor for me, and I thought, wow, what's this going to cost? And I look on the internet and see that it's, those things are kind of expensive if you have to pay for them. But then I got a text from the pharmacy that said it was ready and there was no copay. And then I found out that wasn't because I have insurance, it's because I have Medicare. And it doesn't even go through my Advantage, Medicare Advantage insurance. And I thought, well, why? I didn't know Medicare would pay for all of that unless you actually needed to take insulin. So is that part of this, or am I going to have a surprise soon when they figure out I'm type 2?
I don't really know all the detailed Q&A.
We have a
I
pharmacist
figured that would
here.
be. There's other people in the crowd that could probably help better answers. And then yes.
Hi, I'm Julie Thomas. I'm an ambulatory pharmacist with Ohio Health Physician Group, and I deal a lot with type 2 individuals who have type 2 diabetes and also are interested in the continuous glucose monitoring systems. Sir, right now, do you have a Medicare Advantage plan, sir? Okay, so it might be under your specific Medicare Advantage plan that they are, have expanded the coverage guidelines for continuous glucose monitoring systems to be covered at your local pharmacy. Historically speaking, under traditional Medicare, so Medicare Part B, traditionally speaking, what the coverage guidelines are is that you need to be taking 3 or more doses of insulin per day. Currently, because of the public health emergency related to COVID, they did relax those guidelines to where you were only taking 1 dose of insulin per day. However, that public health emergency exemption is set to expire on May 11th. So what we're hoping, like when somebody said something earlier about Medicaid, Ohio Medicaid covering the continuous glucose monitoring systems at the pharmacies, that is correct. What we're obviously hoping for here is that that expansion of Medicare coverage for continuous glucose monitoring systems will occur. We just don't know if that's occurring yet. And traditionally under Medicare Part B for continuous glucose monitoring systems, one, there is not a preference on system. They don't care if it's Freestyle Libre, they don't care if it's Dexcom, it's just continuous glucose monitoring systems. And historically, you actually have to go through a durable medical equipment company in order to obtain them. So under Medicare Part B, your portion, if you don't have like a supplement, would be the 20% copay under Medicare Part B. But because of your Medicare Advantage plan, I just want to highlight that you may have extended coverage for a continuous glucose monitoring system, and I didn't want to put it out there that Medicare is covering them when potentially they're not. Go ahead.
The reason I am confused about it is because I tried to get the prescription set up with the pharmacy benefit manager for long term, so that every 3 months.
Oh, like in a mail order pharmacy.
And they said, no, you can't do that, you have to get it from, and there's only certain pharmacies that are durable medical equipment
Yes.
qualified by Medicare. So,
Yeah, that's actually good for you.
so I have to go to CVS, but I don't know if they're gonna keep doing that for that.
If we could only predict what Medicare will do, that would be awesome. I would play the lotto right now. So, all right, thank you.
Thank you, Julie.
Something
We had a
I
little
just want to
bonus
add
friend.
to
That's
that,
great.
if you don't mind, if you find that you do not have coverage for a continuous glucose monitor, something to even consider is there's a benefit to using a continuous glucose monitor for a short time. You know, consider using it for 2 weeks or a month. You learn a lot, even from having the opportunity just to trial it. So sometimes that's more affordable. Yeah.
Absolutely, that's a good point.
Coming your way. Hang on 1 second. This is so the people at home can hear you as well.
Oh, okay.
One question I have is, when we were talking about what we eat and how it affects everything, I've had gastric bypass, and so I'm supposed to get in some 70 proteins a day. So I start out my morning with I think it's called something, a protein drink, Premier Protein drink. And my endocrinologist says that those are not good because it messes with your numbers. Do you agree, or do you know why, or are they still good for you? I'm just going to notice that my numbers are goofy.
Right, it's a tight squeeze of what's good for you and what's bad for you. So I think there's probably, based on that, was it a protein shake of some form?
It's called Pure Protein. It's a milk protein, but it has 30 grams of protein.
Yeah. And then how many grams of carbohydrates does it have?
1.
Oh, just 1. Well, I don't see how 1 gram of carbohydrate would cause a lot of derangement of your sugar, unless it's 15 grams of carbohydrates. But what I know is that the shake and the protein, to get 70 grams of proteins in per day is going to be challenging, and that shake helps to get you there. So I think that's the value, especially if it only has 1 gram of carbohydrate, then it shouldn't really make too much of a blood sugar derangement. I hate to override someone else's suggestion or opinion because they know you maybe more deeply than I do, but if it was a sugar derangement, 1 gram of carbohydrate shouldn't make a whole lot of.
My question is, did your physician know which protein shake you were drinking, and did that physician know that there was only 1 gram of carbohydrate? Because that physician may have assumed you were on a standard Ensure that, you know, for the general population that might have 15 or 30 or 20, you know, grams of carbohydrate. So.
I brought in a bottle, so he
Okay.
knows. But he's also the one that says my sugar's too good to have a Dexcom or one of those, and I'm at 7.2, and I take insulin every day, so who knows?
I wanted to say one more thing about the insulin pens. I used to have a gentleman friend who was, you know, Medicare age, and he would sometimes wonder if he took his insulin or not. And those pens with the graphs and the information we have was just such a blessing, because he would be able to know then, you know, no, I didn't take it, or yes, I did take it. I mean, in the case where Dr. Patel mentioned, sometimes we forget, but in his case, he was pretty on it, and I think he took it most of the time. So we wouldn't want him to double up on his insulin. So it can help that way as well. And then Dr. Patel, remind me, so if I forget X number of doses of insulin a week, I think it's maybe 3 or 4, my hemoglobin A1C will raise
I actually
a
know a
certain
number, but it's got to
percentage,
be
but
at least
it
half
might-
an A1C.
Yeah, maybe half of an A1C point at least. So to me, that was tremendous when I heard that statistic, that just missing a few times a week, missing my insulin if I had diabetes would cause my hemoglobin A1C to rise a half or so percent.
Yeah,
So
I would say
that's amazing.
anecdotally, just seeing when people do that, it's an A1C of almost 1 actually. It's really nice when, and then as soon as they do follow those instructions and a little bit more focus or time is committed towards it, you see an 8.4 will turn into a 7, or an 8.0, which they could never get 7, just from that one decision change gets, so by 1, maybe even.
Okay, any other questions?
I have one quick one.
If you're diabetic, should you have an endocrinologist? Did I say that right? Yes. Should we have you?
If you're not taking medication for your diabetes, no. I think that would be overkill. I think, yeah, if you're not taking any medications for your diabetes, oh yeah, I see. If you're saying if you are taking medication for diabetes, if nothing else, gosh, what's the good answer for this? No. So the reality is that there's very, very few of me, and there's many people with diabetes. So if you're on metformin and metformin alone, and you're doing pretty well, and you know what you're doing, you're going to these kinds of classes and highly motivated to learn everything that you can about right dietary intake, you're probably going to get more from that kind of conversation, that kind of meeting, than you'll ever receive in my office space. What I do for a lot of people in my office space is, here you are with 35 units of insulin, or 75 units of insulin, or 200 units of insulin. How do we recorrect or readjust this insulin so that you don't have a low blood sugar? We get your poorly controlled diabetes into a place of good diabetes. So we restructure you, we readjust these medications to realign everything. And even then, once you feel like you're confident to get yourself under control all on your own, at least for myself, I wouldn't want multiple doctors unnecessarily. So it's kind of like you can get a second. If it was me in that position, and even if I'm only on 2 oral agents, I might want to see an endocrinologist one time to say, hey, is my metformin and my Jardiance the right combination of pills for me? I just want to know, and then I know I'm under control, but are these the right 2 for me? This is my structure, and if everything's okay, bye-bye. I think there's value in that. Yes and no. Not everyone needs to see me at all. Typically reserved for those that are using multiple doses of insulin. But absolutely, no, I understand, but I'm just saying, like, the high value is when I'm managing insulin in large quantities. But there's always this second opinion kind of situation where it's like, oh, why are you doing half doses of 4 medications? We can reduce your number of medications by maximizing the ones that you are taking, so you're taking 2 less, therefore you have less adverse effects. I do those kinds of things for a lot of people all day long.
Also, you're a specialist, and there's a lot of people with diabetes and few endocrinologists. So what would be the wait time to get into an appointment with an endocrinologist or in your office? Do you
Right, so
know?
that value of having a diabetes education team around you, there's that quality of life care and learning. All the things that we learned today are so robust and helpful in managing your diabetes care before you really, you wait 6 months for me to say, oh yeah, you're on metformin and glipizide, great. Okay, you're 7.0, you're well controlled, you don't need any adjustments. It could be underwhelming to see me sometimes.
I have a question about exercise. Is it better to exercise in the morning or after supper or in
Yeah.
the middle?
Well, when we look at the habit and building that habit and doing it, it's really a matter of looking at when it's most convenient for you and when you'll fit it in and when you feel like exercising. There's a lot of research out there that is showing that small bursts of activity throughout the day are really, really effective at, managing diabetes and keeping your everything more healthy. So it's not a bad idea to kind of sprinkle your workout out and stay active all day if possible. And just another thing we always really try to encourage everyone is just to reduce the sedentary time where you're literally seated for long periods. A lot of things happen metabolically when we sit for too long. So getting up and doing a small, 7-minute workout or something like that is a really great way of getting up and doing a walk around the block. They're just nice ways to sprinkle that in.
Yes, we got one in the back. Okay.
How many?
So the question was, how much did we interact with that 7-minute workout? What kind of effect do we have on the carbs that we may have eaten this morning?
Oh, I
You
can
need your
check.
CGM to figure that out.
He's gonna check on his.
I actually turned my phone off the entire time in case it started beeping. Actually, it started beeping when I was having low blood sugars right around the time. No, I'm kidding. When did it start beeping that was low? It was before the exercise happened, though. That would have been really cool if it aligned with that. So it brings it down. 15 grams of carbs probably is what we max. No, you think it was more than that? I think 15 grams. I think so.
Maybe a little.
Yeah,
more,
we burn. I mean, we
So
we
think
were
about
sweating a little.
adding that in throughout the day. The goal, really, American Heart Association, is to get about 30 minutes of exercise at least 3 times a week. So if you're looking at those goals, but you can do it incrementally, it makes it a lot more effective and sometimes more pleasant too. Yeah.
Does that 30 minutes have to be continuous?
No.
So
No.
it could be 4 of those 7 minutes?
Exactly. It can be incremental for sure.
Let's not quibble on 2 minutes.
And Natalie alluded to this, but we know that when you exercise, it lowers your blood sugar for a period of time, depending how intense or how long. It might be 1 or 2 hours. It might be 4 hours if it was a long, hard workout. But that's only still a small portion of the day. So if you exercise more often, you are getting the blood sugar benefit throughout the day. So it does really make sense when you have diabetes.
Like Dr. Patel mentioned, education, staying engaged, staying active in this care is really important. We have here at McConnell a monthly education for patients with diabetes. Alyssa, do you want to give a little bit of information on our wellness group?
Sure. We offer a free diabetes wellness group once a month. It's the third Monday of the month, 6:30 to 7:30 p.m. on Zoom. So taking away all the barriers to making it happen. We have information on that at the McConnell table out in the health fair. So feel free to grab a calendar that tells when we're meeting, what we're doing each week or each month. We usually have some sort of topic we're talking about. So it's somewhat informal in the sense of trying to have a conversation around a topic, and we bring in experts on these topics too. So check out that calendar at the McConnell table. Consider coming to our next group coming up. It is focused on, the theme is spring cleaning your exercise routine. So that's next month's topic coming up.
Great. So we are going to transition back to the health fair. The tables are set up out there. If you want to go and visit some of those tables, it'll be open for about another hour. But let's give a round of applause for our speakers today. I think they did a great job.